Good evening, everyone, and welcome to the WICN lecture, Brain Research in Psychiatry, A New Window into the Mind. Professor David Linden, our speaker for this evening, has studied medicine, philosophy, and classics in Germany and London, did a Doctor's of Philosophy and History of Medicine at Oxford, and earned his PhD in neuroscience at the Max Planck Institute for Brain Research in Germany, working with Professors Wolf Singer and Professor Rainier Goebel. He pursued his clinical training in psychiatry at Frankfurt University Hospital, where he headed a psychiatric neuroimaging program there, before moving here to Bangor in 2004, first as a senior lecturer and reader, and since 2007, the WICN Chair in Biological Psychiatry as a joint appointment with the North West Wales NHS Trust and the North Wales Brain Injury Service. Forgive me. Professor Linden's clinical interests are in neuropsychiatry and severe mental illness, and his research interests are in the brain mechanisms of visual understanding, such as visual working memory and its disturbance in neuropsychiatric disorders, and in emotion, especially in the brain's correlations between the manifestations of mental illness and the effects of treatments for those illnesses. Professor Linden.
Good evening. Thanks very much for coming, and I hope you, after this lecture, you will be at least almost as excited as I am about the great opportunities that the modern neuroscience techniques, particularly neuroimaging, afford us with today, especially with regard to understanding mechanisms of cognition and mental experience, and in particular in relation to their disturbance in mental disorders. If you consider this topic from the point of view of a psychiatrist or clinical psychologist who has to deal with mental disturbance, well, with people who may have different experience from the majority of people around them, maybe sort of an unbiased way of describing mental illness. So people have different experience and tell us about them. It's very hard to pin that down. There are virtually no biological markers for that different experience, and in fact there are virtually no biological markers for any mental disorder. That's, not sure whether all of you recognize that. The diagnostic instruments in psychiatry, in clinical psychology, almost all of them do not presuppose any biological concepts, and in fact they are often agnostic about etiology, and that just reflects the fact that it's very hard to come up with biological correlates for mental acts and mental disturbance, and yet we're all aware that there must be biological correlates. Any human experience, of course, has a correlate in the brain. Whatever your detailed philosophical views on these matters are, there must be a neurocorrelate for any kind of perception, cognition, experience, belief. Whether they are the nature of these correlates does not, as already recognized by one of the founding fathers of psychology, William James, the nature of these brain correlates does not allow us to make any inferences about their validity. He made this point with regard to religion. But it may still be of interest to understand these brain correlates, and certainly they are there, and certainly when it comes to mental disorder, we'd be very interested in understanding them in order perhaps to come up with better treatments. So that's basically the situation we're in, and traditionally psychiatry and clinical psychology had to look at the brain as pretty much a black box. There were attempts at looking at the brain post-mortem. That for a long time was the only way psychiatrists actually could obtain information about correlates of their disorders they were looking at in human beings, and their brain pathology was by studying post-mortem brains, which, as I'm sure you all appreciate, although that's very interesting, has lots of limitations. Because normally the changes that you actually observe are decades away from the first manifestation of the illness we're interested in. Now, with brain imaging, we're in a slightly different position. There are lots of difficulties inherent in brain imaging. For example, you have to get your scanner into your building first. We managed to do that with some difficulty, so we've now got our scanner. And we're here and want to understand more about the brain correlates of human experience and its disturbances. Start with a few clear-cut cases. This patient, if you look at the clinical history I've sketched there, middle-aged female person with a history of apathy, social withdrawal, poor self-care. Well, I mean, even a lay person would say, well, that sounds like depression to me. And it was, but it was a depression in all likelihood caused by this massive brain tumor. And there are many, many more people who present with this kind of condition, complaints without a brain tumor, but it does happen. What is really amazing is that you could have very similar presentation with of depression with a massive brain tumor and in a person with no recognizable brain abnormality at all. So brain abnormalities can cause sort of psychotic, affective symptoms. Psychiatric symptoms can be caused by brain abnormalities, but in most of the cases, by obvious brain abnormalities like this one, but in most cases, the vast majority of psychiatric problems are not caused by an obvious brain abnormalities. And that's where our sort of tricky research begins. And I've got another case here. Again, you would say a young patient with a brief history of auditory hallucinations improves under treatment with an antipsychotic. You would normally think, well, that sounds like a psychosis to me, perhaps a transient psychosis or perhaps schizophrenia. Now, this particular person had a tumor, it's slightly less recognizable than the one before, but to a radiologist still obvious, a tumor, a so-called astrocytoma in the left temporal lobe hippocampus area of their brain. Again, with treatment of that tumor, patient would improve dramatically. So that again is a case where there is an obvious and sort of it's treatable in a fairly straightforward way, brain abnormality leading to psychiatric symptoms. But as I said, that's not the classic case that we see. Still, all mental disorders will have their manifestation in the brain at some level, but it's rarely as obvious as in these cases. Now, before I move on, I'll just tell you briefly, for those of you who don't have a psychology or neuroscience or medical background, I'll just briefly tell you a thing or two about the brain. This is a view onto the human brain, the so-called lobar structure, which is a bit of an arbitrary division, but makes sense because these different lobes have kind of different functions and have developed differently in evolution. The frontal lobe being the kind of latest part in evolutionary terms. It's massive in humans, much smaller in any other species, including great apes. The motor cortex here, so this is where the motor tracts down to the spinal cord originate, somatosensory cortex for touch here, parietal lobe areas for visual spatial transformations, visual motor guidance, for example, occipital lobe, so the visual cortex, temporal lobe, auditory cortex, and then there are the cerebellum, for example, is interested in control of movement, amongst other things, and then coming down to the brainstem here, and the spinal cord brainstem having vitally important organs for the regulation, for example, of respiration and cardiac function. And this is what it looks like in an MRI scanner, like the one in Brigante building next door. Again, you see the folds here of the cortex. This is the so-called corpus callosum, which is kind of the bridge between the two hemispheres. As I'm sure most of you are aware, we have this sort of interesting bilateral and largely symmetrical structure in the brain. In any species, really, with the two hemispheres being responsible essentially for stuff going on on the opposites on the contralateral side. So left motor cortex regulates movement in the right limbs on the right side. Is responsible for the right visual hemifield, attention to the right, and vice versa. And this is largely symmetrical, but there are things that are probably not symmetrical, like language. Language, we have a dominant hemisphere, and many of you know that if I was right-handed and probably left dominant for my language, had a stroke to my left hemisphere, I could end up with aphasia, and if I had a stroke to the same area on my right hemisphere, I probably wouldn't. So it's an interesting bilateral structure with some symmetries, but also some asymmetries, which will become important later when we talk about schizophrenia. So we could be talking a lot and covering lots of lectures on just brain anatomy, and that's a great area of interest in its own right. But that's just what I sort of wanted to cover, just as background for the non-specialists here for this lecture. And now I've shown you two examples of sort of cases with clear-cut brain lesions. Now, how about looking at the brain and trying to make sense of the patient experience in terms of the brain in cases where it's not that clear-cut? And I'll talk a bit about the example of schizophrenia, because that's where I do most of my research, and also perhaps because I thought that maybe just the one mental disorder people here may be most interested in, because it's kind of the paradigmatic mental disorder. How is it defined? As I said, there's no biological definition for mental disorder, so it's purely based on experience and perhaps a bit on observation, but mainly on patients' report on their experience. So there's no, if a judge wanted you to say whether a patient is faking a psychiatric diagnosis, there's actually no way really of doing that. Yeah, you could, if you had sufficient knowledge and were a reasonably good actor, you could fake any psychiatric diagnosis, I suppose. Experienced psychiatrists may think that's odd, and may not believe you quite, but it's very, very hard to disprove a psychiatric diagnosis because it's all based on self-report. I suppose you'd have to be able to be prepared to put up with quite a lot of unpleasant drugs if you were to do that. So it's not something I'd advise you to do, but it's just to give you a flavor of how there are just no objective markers of psychiatric disorders. Of course, there is very clever psychometric assessments that can tease it apart, and in the reality, probably very few people, even if they wanted to, would be able to actually convince an experienced psychiatrist or psychologist of a problem that they don't really have. But for example, when it comes to hallucinations, it may just be very hard to differentiate, or it's impossible to differentiate. If someone tells me they're hearing voices, whether that's actually true or not. And in fact, conceptually, it may mean so many things. It may actually not be quite straightforward anyway. And there may not be. It may actually be the wrong question to be asking: is someone, are hallucinations real? It becomes almost paradoxical. Anyway, hallucinations are one of the criteria for schizophrenia. Delusions. You're aware of that sort of paranoid aspect of it. You may be less aware of the sort of disorganized component of schizophrenia, disorganized speech, disorganized behavior, people sort of perhaps dressing oddly, making up new words, just sort of the sorts of bizarre nature of that a certain group of patients certainly display. Negative symptoms, it doesn't mean that the others aren't negative, but it's just sort of minor symptoms, less drive, less enjoyment. So these are just to give you a flavor of what we mean when we talk about schizophrenia. Certain combination of these symptoms would qualify someone for this diagnosis. And would normally lead to social and/or occupational dysfunction. If someone, like the patient I showed you, had a brain tumor leading to these symptoms, we wouldn't call that schizophrenia. This system is not entirely systematic, because people essentially we use these psychiatric diagnoses for people with this presentation and unknown brain cause, because they, of course, also have brain abnormalities leading to these changes, but we just don't know about them. And their causal chain may be different. You may imagine, and there's always a bit of a sort of controversial issue when I say all mental disorders are brain disorders. People may find that strange. And it certainly would have provoked quite an outcry, I think, even just a few decades or just a few years ago. But, I mean, this is just, there's just no other way of conceptualizing it. Of course, all psychiatric disorders are brain disorders. It doesn't mean that they are in some way genetically caused by some brain mechanism. They could be very much caused by psychological trauma, for example. But this can only manifest itself through the brain. The fact that a psychological trauma that you may have endured at age 30 years ago can still influence your actions is through some manifestation in the brain. So that's the sense in which I mean all psychiatric disorders or all mental disorders are brain disorders. It's not discounting the important contribution of psychosocial factors. In fact, it's recognizing them very much, but just saying that these have to operate through the brain. And that's actually a very exciting field of research, how that may happen, and one that's very much active in Bangor at the moment. So one interesting aspect of schizophrenia is, of course, genetics. And this sort of graph just sort of illustrates the strong genetic component to schizophrenia, because if someone has a monozygotic twin who's genetically identical, their own risk of developing schizophrenia is about 50%. And that even seems to be true. You might say, well, they were raised in very, very similar environments, so any effects of, say, the mother would be impacting in the same way on both. Of course, that's true. But these effects even come through in so-called adoption studies. If you look at siblings that were raised in different families, or you can, by comparing monozygotic and dizygotic twins who essentially share exactly the same environment from even pre-birth, but dizygotic twins are not more similar to each other than other siblings, you can see that there's a very strong genetic contribution to schizophrenia. Again, this doesn't mean that it's all biologically determined, because 50% or so is environment or gene-environment interactions. But it's we have to keep this in mind. And this is actually interesting. What was interesting about this, fascinating, I think, is there is a very strong genetic component to schizophrenia, depression, bipolar disorder, even substance abuse. So, which means there must be, this means biology. So genetic contribution means there must be a very strong genetic component. And yet we know so little about the actual biological implementation of these disorders. And regardless of decades of research into the actual genes behind schizophrenia, which will be a multitude of genes, certainly not a single one, from the pattern of inheritance, we still know very little about this, which is both frustrating and fascinating. And it must have a strong genetic component, and yet a strong biological component, and yet any study we do just only gives us very, very small effects. And one of the effects that have been observed fairly consistently when looking at the brain in schizophrenia is enlargement of the ventricles of the brain. And this is an example. These are sort of fluid-filled cavities in the middle of the brain, and you see here in just one pair of cases, it's enlarged in the twin affected with schizophrenia and smaller in the unaffected one. And this was the classic finding in the 70s for the sort of biology of schizophrenia in terms of brain imaging, and it still holds true. But if you look at this now, a study which actually plotted the distribution these are schizophrenia patients here. They looked at different groups here. But if you look at the comparison subjects here, now I don't want to say anything wrong because Chris Whitaker is here, who's the statistics expert, of course. But the means are different. The mean ventricular volume in these two groups, and they were statistically significant, and they looked at that with clever tests, t-tests, for example. But if you look at and that's something I learned in these statistics classes here, you always have to look at the distribution. And if you look at the distribution of your values here, you see that there is a lot of overlap between the control subjects and your patients. And if you wanted to use these values as a sort of diagnostic marker, you can already see that they'd be pretty useless. If you said anyone above this mean here, for example, would be classified as schizophrenia. Now that would leave you with about a third of the normal population being classified as schizophrenia. That's not if you wanted to use it as a diagnostic test that would allow you to treat people, that would be absurd, of course. So just to give you a flavour that these measures may come out significant in large groups, significantly different, but don't have this, what we call sensitivity or specificity sufficient for diagnostic tests. So you'd never be able to base a diagnosis on this. And this is the problem a bit with almost all biological, not just brain imaging, but also hormone levels and sort of other potential biological markers of schizophrenia. And it's not quite clear why that's the case, because there seems to be something there. Almost all studies report these wider ventricles, but it's and yet the overlap is so large. One reason may be that what we call schizophrenia is actually a very wide phenotype, may encompass lots of different disorders. And if we could only single out those who are the ones with actual schizophrenia, we'd get much better discrimination. Or we may sort of clustering people together based on diagnostic criteria may not be a good idea, and we may have to go down to the single symptoms, for example. And I believe you discussed that with Professor Bentel in a lecture a few months ago, whether these diagnostic concepts actually made any sense at all, and that is a very interesting question in its own right, which I'm not going to cover much. But these problems like this may explain to you why people may get doubtful about diagnoses like schizophrenia. When you then come back to findings like this, I know Richard's got arguments against findings of this type as well. These would often be used then to support these diagnostic categories, because 50% heritability is a fairly strong argument. So it is very difficult to come up with a sort of unified view of these psychiatric disorders like schizophrenia. Another interesting area people have looked at is the planum temporale. Now, why should you be interested in the planum temporale? It's one of the areas that are crucial for language. This is where the area for understanding speech is localized. And it's interesting that in most individuals there's an asymmetry. It's large on the so-called dominant hemisphere, up to twofold actually. It varies with studies. So in left-handers, left hemispheres, the planum temporale would be larger on the right. And quite a few studies now have demonstrated that the planum temporale, again with some overlap, planum temporale is smaller in patients with schizophrenia compared to healthy comparison subjects, particularly on the left. And this may be related. People are fascinated by this because quite a few of the symptoms of schizophrenia are related to language, making up new words, even very, very early so-called prodromal symptoms, deficits in understanding speech, and hallucinations. So this is an interesting area. Now, we've looked at this as well a bit. Because with all these measures in patients, you may say, well, there's so many reasons for why things may be different in patients: medication, time spent in hospital, nutrition, they exercise less, and so on. So we looked at this issue in patients, and we're by no means the first to do this sort of research along these lines, in patients, first-degree relatives of the same age group, and control patients, again looking at the volume of this area, the planum temporale, which is indicated here. And what we saw was that, first of all, patients had smaller volume in this area than their relatives, and relatives had smaller volume than controls. So there seems to be a sort of possibly genetic component to it, as he's explaining part of this, because the relatives function completely normally, are not on any medication, and so on. But also the asymmetry that we saw in controls, left larger than right, the sort of normal temporal, planum temporale asymmetry that I mentioned, was reversed in the patients. We computed a sort of similar sort of symmetry indices or lateralization indices with data with functional activation as well. And I explain what functional activation is later in a different context. So we computed a lateralization index, essentially comparing the left and the right hemisphere, and controls were on all these measures more lateralized to the left than the patients. And this actually correlated with symptoms. And now the next question was, what does this mean? The sort of reduced lateralization, the normal lateralization sort of reduced or even reversed in schizophrenia patients. Does that actually explain partly why they hallucinate? So we, as I said, we looked at correlated these individual values with their individual symptom levels, and that's not necessarily, it's not a simple thing to do, because how do you measure symptoms? Again, you have to interview a patient and ask them about it, and there are scales like this one, the positive and negative syndrome scale, where according to certain criteria, so definition of hallucination, perceptions which are not generated by external stimuli, you rate their severity. And when we did that, we found that the lateralization was actually correlated with their hallucination. So the less, this negative correlation, the less lateralized their brain activity and brain volume in the temporal lobes were, the more prone they were to hallucinations and also to other psychotic symptoms. So this, may I mean, it's not straightforward to interpret, but it may mean that if you have this vulnerability of reduced volume of your temporal lobe and reduced lateralization of volume and activity in the temporal lobe, you're more prone to developing hallucinations, which could be related perhaps to reduced sort of inhibition across hemispheres. It's not the mechanisms are not clear, of course. I'll come to the mechanisms in a bit more in a moment. But what's interesting about this type of research that we may actually have a biological marker here for the genetic vulnerability to develop schizophrenia in the volume and lateralization of the temporal lobe, because we have this very important intermediate finding in the relatives. Now, this was mainly on brain structure. When it comes to how the brain's activated, we can again look at that with imaging, with a slightly different technique that's based on picking up blood oxygenation. We can look at neural activity by looking at the inflow of fresh blood it produces, because if we have neurons active, they consume energy, they need fresh blood, like muscle would, and that we can pick up with the fMRI, with the scanner, the so-called functional MRI signal. And now, if we wanted to know, when we did want to know how these sort of structural changes in the temporal lobe may then lead to hallucinations, and we had people who actually were hearing voices in the scanner and were measuring them with this functional signal, and what came out was that actually this area here, again in the temporal lobe, the hearing area of the brain, more specifically the primary auditory cortex, was actually activated during hallucinations, very similar to when they were actually listening to speech. So we can now, with these techniques, look at the direct correlates of symptoms and almost confirm, yes, well, you are having activity in your primary auditory cortex that may at least suggest that you are also having some vivid experience in this modality, for example, hallucinations. Not by no means an objective measure. I can't exclude that by really concentrating and imagining trying to imagine very vividly, although most studies of imagery don't actually show this type of primary cortex activation, you may be able to fake this. It's not a lie detector for psychiatric symptoms, but it shows us that in the normal case of people experiencing these auditory hallucinations, they actually do get activity in these sensory areas, which may explain the vividness of them. And together with the structural finding of decreased lateralization that I showed you, may actually give us a handle on understanding the mechanisms behind this experience, and in fact try and improve treatments as well. But the missing link, in a way, between structure and function is connectivity. Brain areas, no brain area operates in isolation, and brain areas are connected by, imagine, cables, essentially, in the white matter. We've got the so-called grey matter here, which is the cortex. That's where most of the actual sort of computations happen. But then when one brain area wants to talk to another one, it has to go through fibers like this, so-called arcuate fasciculus here. And one interesting aspect of patients with hallucinations is that contrary to most of the rest of the brain, where the connectivity, if anything, is disturbed in schizophrenia, they seem to have increased connectivity, as if there was sort of a direct path from the language production to the language reception areas. And in fact, in our fMRI studies, we normally find both language production and speech reception areas active during hallucination. And the fact that there is a change in these fiber tracts may actually explain part of that. Again, now the next step would be to look at whether that's the case as well in relatives, and whether, that type of research hasn't been done yet. And this is using, again, an imaging technique, diffusion tensor imaging, it's called, and incidentally, one technique where we'll also be able to use here in our imaging center. Now, just as my final bit on the sort of side of symptoms, you may be interested in knowing whether the same pattern as we just discussed for auditory hallucinations is also true for other modalities, because hallucinations could occur in any modality. And in fact, we did manage to look at a patient with visual hallucinations, which is a bit even harder than auditory hallucinations because they're, in schizophrenia patients, rarer. What I'm showing you here are essentially, if we focus on this, cuts through this patient's brain. And what we did here, we mapped certain areas that are interested in particular visual categories. So, for example, we mapped the yellow area here, is the so-called body area. Incidentally, an area discovered by our colleague Paul Downing a few years ago. The body area is particularly interested in bodies, and we looked at the place area, for example, in blue here. So this is just with visual stimulation. And then we found the areas in red here, where when the patient was hallucinating, this person was hallucinating people in strange rooms. And we found that in response to these different categories that the patient was hallucinating, he also had activation in these very specific areas, which I thought was sort of interesting. Again, speaks to the essentially sort of homogeneity between internally and externally generated perceptual experience at the brain level. To sum this up, we're now very interested in looking at people who have hallucinations or hear voices, but wouldn't sort of qualify as patients. Certainly wouldn't think that they are too bothered by them. So-called benign hallucinators. That's ongoing research here in Bangor with Dr. Mike Jackson and PhD student Katie Thornton, and she just had I don't know whether you'll get the North Wales Chronicle. Just surprised to see an advert for our study on the front page there. So it's, and this is just not because I want to hijack this a lecture for recruitment, of course, but just to give you give you an idea on how much this research also actually interacts with the community, because we've been on the radio to discuss this, and it's there are many people around who have experiences like this and are actually interested in what's going on in the brain. We, of course, are interested in what, in terms of brain mechanisms and psychological mechanisms, discriminates hallucinations, for example, that are experienced as being benign from those that are experienced as unpleasant and pathological. And so we hope that brain imaging will be able to will be one component in helping us to elucidate this difference. Now I've given you, I hope, some flavour now on how we can use these new brain imaging techniques to obtain a better understanding of mental phenomena, diseases, and their biological mechanisms, and in particular of looking at specific symptoms. Now, can we also use these tools in order to treat them? Well, that may be too bold a claim, but at least we can look at treatment effects in the brain, which again is something that is not a classical pursuit of psychiatrists or clinical psychologists. Quite unlike the rest of medicine, or healthcare, where you always need biological markers. You want to treat diabetes, you look at glucose levels, I suppose, or if you want to treat high blood pressure, you look at blood pressure. If you want to treat schizophrenia, what's your outcome measure? That's very, very difficult to do. And I'm not saying that the measure should be replaced by brain measures by no means, but it's certainly interesting to look at these changes produced by treatment in the brain. We are optimistic that that is possible because lots of things change the brain. I mean, anything. Brain is always continuously changing organ, and there's certainly quite a bit of research on how practice changes the brain. You may have come across this type of research looking at motor cortex with a technique called MEG magnetoencephalography. Similar work has also been done with imaging. Control subjects here, these people, twice as much sort of hand area, if these MEG measures are reliable, but let's assume that for a moment, twice as much hand area in these string players, but only in those who started early. In case you were considering taking up an instrument, I guess most of the people in this room would be maximally here, but still, it's probably still worth doing that. But really, if you want to use the optimum plasticity, you have to start early. And this is very interesting research. You could do the same for language, and again, that's something, development of language, certainly development of bilingualism, looking at these with these techniques, very much active research in Bangor as well. Now, this was just practice, and but most psychological interventions are some sort of practice as well, or changing your thought patterns, not necessarily becoming better at some movement, but becoming perhaps better at some way of thinking. And most of the, at least there's a group of disorders, phobias, for example, which can be conceptualized in the context of classical conditioning. Response to a spider, for example, in spider phobia. And so we can use the models of research of this example here, Pavlovian conditioning, to understand their biology, how certain stimulus response associations may be conditions or unconditioned, and so we can draw on quite a bit of animal research for models for these very simple models of certain mental disorders. When it comes to more complex, certainly sort of language-based disorders like depression and schizophrenia, animal models largely fail, or have failed so far, actually. So essentially I'm trying to motivate, sort of a fairly lengthy introduction into why it may make sense to look at effects of psychological therapies in particular with brain imaging techniques. And because again, that is a proposition that until very recently, many people would have thought as slightly odd. We know that practice changes the brain, and we can measure that. We know that stress changes the brain. There's at least some evidence for stress leading to reduced size of the hippocampus, an area crucial for memory, but probably also for emotion-cognition links. These were sort of graphs here showing hippocampal volume in people with PTSD in relation to the length of exposure to combat. And similar findings were obtained for length of depression. This is not clear-cut by no means, but at least there's some evidence for stress generally, but also stress in the context of depression leading to changes in the brain. So if we alleviate that stress, may some of this brain structural deficit be reversed? That no one knows so far, but it would certainly make sense to look at this. And now looking directly at brain changes produced by psychological interventions, it's actually sort of work we did, looking at the effects of hypnosis on pain perception, which, as I'm sure many of you are aware, is pretty remarkable. And in this case, the hypnotist induced a so-called out-of-body experience. And if you were wondering what that meant, I found an illustration of that here, during which people were very attenuated in their pain perception. And if we looked at, and that was in the scanner, so we compared the activity during dissociation to a control state, and these red areas are those with reduced activity. And what we found was that the same objectively, same noxious stimuli, same electric painful stimulus, or noxious because they weren't actually painful during the dissociation, or at least much less. Same physically, same stimulus produced much less activity in sort of somatosensory touch area and in emotion-related areas like the amygdala, which I think is remarkable. It also tells you that these psychological interventions really change the brain. Well, this is a simplistic way of saying it. Of course, it's stimuli that, like the voice of the hypnotist, starting process in the brain that will then lead to a state in the brain in which the pain processing is not processed in the same way up to somatosensory cortex and amygdala levels, but induced just by a psychological technique. I think this is quite interesting. This has been looked at by other groups in sort of psychiatric disorders as well. In this case, spider phobia, looking at the brain response to spiders before treatment and after treatment. And as spider phobia can easily be treated, brief course of behavioral therapy. Essentially, exposure therapy has a 110% success rate, and this is what happened here. And the brain response to the spiders that was there before treatment wasn't there afterwards anymore. Yeah, I mean, there are various ways of interpreting this, but I just sort of wanted to give you a flavor of a few examples. Moving up to sort of perhaps more complex disorders, depression. It's harder here to look at these issues because how do you recreate depression in a scanner? With spider phobia, it's pretty straightforward, just show them spiders. With obsessive compulsive disorder, for example, it's still fairly straightforward, just touch them with something dirty, or, in depression is too complex, really. You can only always look at symptoms, perhaps even, and part of the depressive syndrome. And most of the research there was actually just looking at metabolism and blood flow during a so-called resting state without actually trying to induce symptoms. And there are lots of problems, methodological nature of that, because if you don't have a paradigm where people are there in the scanner and you measure their blood flow, there could be so many things going on. So this type of research is not very straightforward. But what was interesting still is in this study, people looked at the brain difference in brain activity. In this case, it was a technique called PET, which is sort of using radioactive markers to look at blood flow. And the red areas here were those where activation became higher after successful treatment, and the yellow areas were those where activation became lower. And you see here essentially a similar pattern, even if you didn't worry about the actual brain areas. Same areas in deactivated and more active in both groups. And what's interesting is this was a group with an actual antidepressant, Prozac, and this was a group with placebo. So this group had a kind of, placebo, of course, is the, it's essentially the psychotherapy without a therapist. So it's an all spontaneous recovery. But this sort of study caught quite a lot of attention because it demonstrated very similar patterns of brain metabolism in the placebo and the drug response. But one of the reasons may be actually that all they were looking at was spontaneous recovery from depression. So we are at the moment very interested in this type of research and looking at, I'm very interested in looking at effects of psychological therapy on symptoms and their correlates in the brain, but also we're doing what probably is the first study of using these techniques to look at electroconvulsive therapy. Because that, again, is a treatment technique about which we know very little in terms of brain mechanisms. So at the moment, we're looking at, and as I'm sure many of you are aware, electroconvulsive therapy is a very effective treatment, normally only used in people who don't respond to a number of drugs in mainly severe depression. It's very effective, but no one really knows why. And we're looking at emotion response in these patients and their brain correlates before and after a course of electroconvulsive therapy. That's joint work with Professor David Healy over at the Trust. I can't show you any data, but if you're interested, some of our students, master students, will present data tomorrow at the BPS student conference. The first single case we've looked at here. So, but unfortunately, we only managed to do the analysis until just before the lecture, so didn't give me a chance to incorporate this. But it'll be there tomorrow at the student conference. Okay, so far we've looked at conventional intervention and their possible brain correlates. Can we use these techniques now in order to develop new interventions? Now that sounds even less likely, but and we don't know whether it'll ever be possible. But let me just try and explain why I think it's still worth spending time and incidentally WICN money on on these issues. And this project's been approved, so I'm not actually needing to advertise it here. But let me explain. So this. This one, the first, let me introduce this by referring to a technique we're not pursuing here, and this is deep brain stimulation. And again, that's maybe something you've come across. If you remember sort of vaguely the slide I showed you about placebo response, they and Prozac, they had an area called the subgenural cingulate. Don't worry about it too much. It's the part of the brain under the genu of the corpus callosum, but it doesn't really matter for our present purposes. This is an area which this particular group always found to be too high in activation during depression, and then to go down after successful treatment. So they thought, well, can't we perhaps shut this area down? And they found a neurosurgeon as collaborator who replaced electrodes in this area, and then with sort of deep brain stimulation, similar protocol to what people do for Parkinson's. For those of you who were at Alfons Schnitzer's lectures on deep brain stimulation of basal ganglia for Parkinson's, a similar idea, and they're trying to shut down this area, and then looked at depression levels after 6 months, and a few of their patients actually improved, and of course. These are patients, the criteria for this are even stricter than for ECT, of course, the patients who didn't respond to any treatment, really, that's available. I found this vaguely funny, but my wife tells me it isn't. I'll leave that to you to judge. But it kind of, what is sort of the link is, it seems a bit of a haphazard approach. You certainly wouldn't want to have brain electrodes in the hands of psychiatrists. Now, of course, these people collaborate with serious surgeons. Okay, and there are lots of issues we may perhaps discuss about this deep brain stimulation. It just really got me sort of us and others sort of thinking about alternative mechanisms, less invasive mechanisms of regulating particular brain areas, and perhaps ways that make more use of the patient's own facilities and use more the concepts along the line of sort of self-efficacy rather than having the patient really only passive as you know, experiencing effects of electrodes. And the technique which may come in here is neurofeedback. And again, that's something we're pursuing here, which essentially is the idea that you modulate the area, the activity in a particular brain area by biofeedback. People have tried that before, and decades ago with heart rate and blood pressure, and it sort of works reasonably well. But now, for our purpose, it would be great, of course, if you could identify. Let's assume we could identify an area that's bad for you. If you could train you to drive it down or upregulate, the happy module, wouldn't that be great? So, and we can now do that in the scanner. At least technically, it's possible to have you observe your brain activity in a particular area and then try and train to up or down regulate it. And it's based on sophisticated installations in the laboratory, but by now quite a few groups are doing this. And one of the early studies on this was just looking at how people self-regulated their motor cortex, and I'll show you examples of this from our own lab in a moment. So this is just a screenshot of a movie, and I'll just try and run the movie and explain it along the way. So essentially this busy screen is from an experiment where we had a person, incidentally it was myself, in the scanner, just doing hand squeezes, just squeezing their right hand. And this is the time course of brain activation in real time, and that's what's interesting. So signal comes out of the scanner, gets analyzed, it's shown there, or analyzed with a sort of simple percent signal change is being observed here. So this is the contralateral motor cortex here, going up to 8% signal change, so I'm really working hard, and this is the ipsilateral motor cortex, which is less interested at, what I told you about contralateral connections. So this is what's sort of interesting here. Neurophysiologically, this is trivial. Of course, if I, activate movement of my right hand would be accompanied by activation of my left motor cortex. But the technical challenge it was to show it, and to have this sort of analyzed in real time. And this is what I was seeing during that time. It's kind of an indicator of the activation I was producing. So I could grade it according to, how much activation I wanted to produce. I knew they gave me instructions, for example, now stop. And then, I was to squeeze my hand. And as you see here, it's coming up. There's always a slight delay. It takes a few seconds for the blood to come in, but I'm managing quite well. Moving my hand here, you can see activity here going up nicely during this blue period of where the instruction was to move my hand, and this is my indicator, so I could play around with it a bit. Okay, well, I hope you find that vaguely interesting, but it's not actually the interesting bit, because of course, if I move my hand, motor cortex activity would go up. Now the more interesting bit comes next. Now the instruction was to do the same, but without moving my hand. So I was there in the scanner, and they told me, stop. Okay, fine enough. It's going down, always sort of a bit sluggish. And then we have the instruction move, but what it means is imagine, or the instruction is now upregulate this motor area, but don't move your hand. So I'm having to imagine doing something, or coming up with my own strategy to upregulate this area, and well, I'm doing all right. It takes some time to develop this. Slightly odd experience at first, but after a while, and we've done this now with a few students as well, and they normally manage to get their sort of these higher motor areas we're looking up to at least half the level of the activation you'd be producing by actual movement. So again, slides. I'm coming up there. So this is the activation. This is an indicator of the activation in these higher motor areas. I'm producing without actually moving my hands. Now, it had been known, of course, that by motor imagery I can activate these areas. So this is actually, again, in neurophysiological or cognitive terms, not new. It's just, but I can certainly enhance and control that with training procedures. So the next step now would be to use this on areas where there is no obvious strategy to control it, and that would require this training for this motor, for controlling my motor cortex by imagery, only takes 10 minutes. And for areas where it's less obvious how I regulate them, it may take hours or days, or multiple sessions. But this would be the more fascinating application then, if I could essentially get through this training, learn strategies on how to regulate brain areas where I don't have an obvious way of getting at them. And that's ongoing research, exploring the feasibility of this and then exploring clinical applications. There has been one American group looking at pain, and with some promising findings in chronic pain patients where pain levels were reduced when patients learned to self-regulate the particular area of the brain, their anterior cingulate cortex. And we're, at the moment, very interested in exploring these further in terms of self-regulation of emotion, really. And again, that's collaborative research we're pursuing with David Healy in the field of emotion and affective disorders, and with Professor Miles Cox in the field of addiction, because again there we see very interesting applications in terms of using this as an adjuvant, really, to psychological strategies for training self-regulation. I should mention for the movies, it's a pleasure to acknowledge help of our collaborator, Dr. Steve Johnston of the Brain Imaging Center, who's implemented a great deal of this setup at Bangor, and I'm pleased to report that it's now working. And in fact, if people are interested, we're so sincerely interested in people's experience with this, and if you're interested in learning how to self-regulate your motor cortex, for example, talk to us. Or if you have particular ideas, if you're a musician, for example, and want to explore whether this way of practicing may help you improve your skills or in sports, there's maybe things to explore as well, in addition to our core clinical interests and sort of clinical applications. And I cannot acknowledge the multitude of collaborators and mentors and people who influenced and have taken part in this research, just the core institutions and the core funding bodies on which this research depended, really. And now I'm really looking forward to your questions.
Judith Moss, art therapist. Francis Kaplan, amongst other writers, have reported on the good effects of the arts on the brain, and I'm wondering if your research reaches into those areas, into that field.
Right. Now, the question was on the effects of art on the brain, and I believe in the context of art therapy, which is your art and music.
Drama and the arts.
Yes.
Yeah.
I'd love to be able to tell you more about this, but I can't really, because it's an area I'm fascinated by, but I haven't done any research on. But there can't be any question that the uplifting effects of music, for example, have correlates in the brain. I would believe that there has been work done on this, both from a sort of neurochemical point of view, changes in terms of hormone levels, for example, probably not so much in terms of brain structure. But it's perhaps we can refer this issue back to Donna, the organizer of this series, because there's actually an increasing interest within our school in both the neural correlates of art perception, art appreciation, and music appreciation, more in the area of developing expertise in these areas than in the sort of therapeutic effects. But this is where I see a great development in sort of neuroscience. In fact, there's a whole field of neuroaesthetics now developing, and it's certainly one where I think Bangor will play a major role, because quite a few colleagues are now pursuing that as their main interest. So I'm hoping that in one of the next WICN lecture series, perhaps you'll be able to hear about that from people who know about this in a more professional way.
How do you relate the molecular theories and treatment to the structural changes you see in the brain?
Now, that is a very interesting question. Perhaps I should just expand a bit on this issue of molecular theories and treatments, because I've omitted that from my lecture, and it is, in fact, the area most people think of when we talk about biological psychiatry. In the case of schizophrenia, for example, the idea that schizophrenia is produced by a dysregulation of the neurotransmitter dopamine, neurotransmitters being the chemical substances that mediate the communication between neurons. In fact, the treatment, the standard treatment still, pharmacological treatment, medical treatment for schizophrenia is with drugs such as haloperidol, which are so-called dopamine antagonists. So they block the dopamine system. On this basis, people would think, if blocking dopamine receptors has a positive effect on psychiatric symptoms, well, it would probably be an underlying imbalance of the dopamine system. And there's a lot of evidence for that, but there's also a lot of controversy around this. Directly from brain structure and functional imaging, we can't infer that much, although we can, because there are areas of the brain, for example, which we know have a lot of dopaminergic modulation. For example, the ventral striatum, the so-called motivation network. So if we see changes in structure or functional activation in these areas, we may infer specific neurotransmitter effects. Another way of looking at this is through looking at using spectroscopy with MR imaging, which has a more molecular resolution. And one area I'm particularly interested in is, which I didn't mention today, is genetic imaging. So what we try and do is get participants with a different genetic profile, for example, affecting their metabolism in the dopamine system, and then see whether that would predict different levels of functional activation. For example, there has been research on serotonin, which is another important neurotransmitter implicated both in psychosis and in depression. People with different levels of serotonin metabolism showing different responses in their amygdala to emotional phases. That type of research. So there are links. And another way of looking at it would be to see, perhaps the most direct way, if we had a pathological pattern of activation, say the hyperactivity of the auditory cortex during hallucination, would that disappear after treatment with a specific agent, for example, dopamine blocker. So there are ways of linking the molecular models with these sort of more global brain structural models, but they're not straightforward actually. Imaging with PET imaging with radioactively labeled dopamine or dopamine antagonists would be another way of seeing whether changes in this activation signal we see with the fMRI and the receptor signal conform. I don't know. I mean, I've answered this in very methodological terms. I'm not sure whether that was satisfactory. At the moment, I don't think there is a model that would unify the molecular model and the sort of, for example, the structural asymmetry model or loss of asymmetry model in the temporal lobes. I don't think there's any straightforward way of linking that to the dopamine model. We know too little about the neurodevelopmental mechanisms underlying these structural differences at the moment in order to unify these.
There's something slightly scary and amazing about the biofeedback studies you're describing towards the end of the talk. Is there a danger that you might get so good at stimulating your happy center in the scanner that you lose your interest in neuropsychiatry?
Well, some of the ideas we were pursuing with Miles were actually going in this direction a bit in terms of using it to as an additional reinforcer when people are learning new motivational goals. Move them away from alcohol or nicotine or other substances of abuse to more positive goals. We thought mainly along the lines of money, actually, but you may think that money in many respects is actually more harmful than alcohol. So the answer is yes, flatly yes. It has to be handled with extreme care, I think, but that's probably true for any self-enhancement or any psychological meditation could have the same effect. I could lose interest in your psychiatry completely because of meditation. So the answer is yes, but it may not be qualitatively different in these sort of ethical terms from other psychological interventions. But and yes, we're using it. I mean, it would be very interesting to see whether it actually has a motivational value. It probably does in terms of just gaining. If you use this as a game. And that's how if it will work, it'll work through the most successful neurofeedback studies actually did use money as a reward for good performance on these sort of self-regulation games. So people can perhaps even get addicted to doing this kind of thing. Yeah.
You mentioned the effect, the emotions, quite briefly. But I understand that cognitive therapy and cognitive neuroscience has a way of controlling or adapting the emotions or making sense of the emotions. And I wonder if the chemical effects of emotions have been explored, because I do believe that feelings that are unacceptable, that none of us want to own, like stress, anxiety, anger, fury, sadness, loss, all those kind of feelings are things that we don't want to know about or feel. So what do we do with those, and what chemical effect might they have on the brain?
Slightly modify your question. One issue actually is chemical versus psychological effects, and I think that's another fascinating issue. May a psychological intervention, for example, cognitive therapy for depression, operate through the same mechanisms like a chemical intervention, and that's sort of coming back slightly as well to the sort of molecular models, and there's some evidence that partly it does and partly it doesn't. So one interesting study suggested that the comparing cognitive therapy of depression with drug therapy, that cognitive therapy actually reduced the level of prefrontal activation because ruminations were less. The guilty ruminations often that patients are often vexed by so much were actually reduced, and that was reflected in less frontal activation, although that was really inferring from the brain activity, whilst the chemical operated more through the brain stem lower level mechanisms in reducing the impact, the sort of drive produced by these negative emotions in the first place. That's very preliminary data, but just to tell you that these techniques in principle would be able to explore these issues. They're pretty good at looking at the networks associated with individual emotions. Again, that's research we're doing here as well, for example, in regard to anger. What are the brain systems that respond to anger? That's essentially this functional MRI is perfect as probably the best technique for looking at questions of this sort. In terms of the brain activation, then it'll be the next step to figure out how it works chemically, and the kind of work we're doing with the genetics may give us a handle on what neurotransmitter systems may be involved there. Then the next step to treatment. Well, again, in the sort of neurofeedback context, you could imagine if you said my aim was to reduce my anger, I've identified my anger network. In a way similar to anger management in purely psychological terms, if these are emotions that we tend to not want to reflect on too much and that we can't access really, in a way for these neurofeedback techniques providing us with a way around these repressed emotions. It's one way of thinking about it. Whether it'll ever work and whether we want that to work is a different issue.
I don't know whether you're familiar with the Dr. Hammer's work, who worked with cancer patients in Germany and came up with emotional issues, stress issues they had at a certain stage before the cancer actually started, and they were located in the brain, which are then, depending where it was in the brain, they were then correlated to different organs in the body. And so therefore that particular organ was affected with the cancer. Have you heard of that? Have you been?
No, that sounds very interesting. No, it's not research I'm familiar with.
I'm very fascinated by the work you are doing, and I think it's very exciting. And I'm a hypnotherapist and NLP practitioner. I was also very interested in, you just mentioned a little bit about hypnotherapy and how it affects the brain. And is there any more studies on that? Because that would be also very illuminating.
It's mainly looked at that. They've mainly looked at effects on pain processing, because if you can have a stimulus, these techniques work so much better. So that's why most of this research has focused on the analgesic effect of hypnosis. People have also looked at the correlate of the hypnotic state, but that's harder to look at. It's a bit sort of getting a bit fuzzy. If you wanted to look at more general benefits of any technique on well-being, that's where it becomes very, very difficult to do. So that's why. Excuse me? Meditation was. Yes. Again, meditation. But that's another fascinating issue. You can certainly look at brain activity during states of meditation. It's difficult to do that well, because there can be so many. We'd ideally, even with this type of research, we'd still try and be experimental psychologists. So we try and manipulate just one isolated function or mental operation at a time. With meditation, that would be very difficult to do. For example, if we can. Yes, so that's why this is often difficult, and it becomes even more difficult if you wanted to look at sort of global effects of meditation. If you wanted to look at effects of meditation on something that can be easily measured, for example, your ability to self-regulate first of all, something conventional, say speed on some task or memory, for example. Whether your visual memory becomes better with meditation, you could easily look at that. But you could also now look at, with the feedback tools, whether your ability to self-regulate a particular area would improve with meditation. I think there are lots of sort of new ways of looking at effects of very complex mental processes for which we don't have ways of looking at direct correlates, really.
So a lot of the functional research that you showed highlighted with psychiatry patients showed the kind of negative symptoms of their disorders. Do you feel that there's a point to actually look at the positive symptoms that some psychiatry patients have? So, for example, in schizophrenia, maybe creativity and how that would affect their functioning.
Right. Okay. Yes, that's very interesting. There's a terminological issue, because the way you use positive symptoms is in the sense that psychiatrists wouldn't, because the positive symptoms of schizophrenia are actually negative in your definition. The so-called positive symptoms are psychotic symptoms, are where people have more. The negative symptoms are those where people have less, like less joy, less drive. Of course, what you mean is all symptoms are essentially the negative class, pathological, and then you're talking about the positive experience, and like creativity, which is that is a very interesting issue, and people will probably vary in their view whether there is such thing as a positive experience associated with psychosis, and that probably varies a lot according to the individual experience of patients, whether they view it that way. But certainly, it's absolutely important to consider this. Certainly, across the population, there must be a benefit in some of the schizophrenia genes. Otherwise, they wouldn't be around anymore. And the big question is what that is. And creativity, we don't know. It may be creativity. If you think about if you think about mental disorder, not so much as a clear-cut pathology, but as in the sense of the continuum model that's very popular at the moment, and there's the idea of schizotypy. So we're all somewhere along the schizotypy scale, more or less. And then where you make the cutoff for a pathological diagnosis is pretty much arbitrary and a convention of society. And if there are continua, multiple continua of this sort, each with their genetic contribution, they all have a certain functionality. And perhaps only if you have the wrong combination of these individually functional genes, you end up with a pathological state that would make it hard for you to cope with society. So these are ideas of how a clearly strongly genetically associated condition like schizophrenia could still be favored by evolution, because the individual genes actually confer benefit. It may be a combination of a creativity gene, perhaps language gene. It's a controversial position proposed by Tim Crow, and with these sort of asymmetry ideas, there may be something to it, and perhaps other unknown functions. So if you had a combination of these individually functional genes, which in particular combinations in sort of polygenetic disorders produce the actual pathological state, this way is a way of explaining how they how these genes can evolve with humanity as a species, and of course in this context there is scope for a positive experience associated with a disorder, which would be very interesting to look at. Probably first with not so much with brain tools as with sort of more psychological tools, explore whether creativity, for example, actually is enhanced is increased in people with schizophrenia, and in what way it is. And there are certain individuals where this is true. I don't know whether it was satisfactory or true biologically. It was just sort of the kind of thoughts I sort of triggered, or my way of sort of looking at this in the sort of continuum and sort of a genetic model.
I was thinking along. I've read quite an interesting paper by Burns, who looked at it as like a costly trade-off of schizophrenia and how how the prevalence was still in the population. I just wanted your view on that, really.
Right.
Great. Cheers.
Right. I think generally the field is moving away from this categorical classification. I mean, it's still used in the sort of health service and with some justification, but it's being felt more and more that just calling a cluster of symptoms, labeling that with a certain disorder, name of a disorder, may not capture the complexity of individual experience, and may not capture the complexity of the associated biology.
Hello. I just have a very practical question which was interesting me. I was trying to imagine you recruiting, some people who are quite ill, perhaps who lack motivation sometimes even to speak to other people or to, attend therapy sessions or whatever, to get them to go along and to take part in your research. Obviously, it must be quite difficult in the first place. But then having done that, if you do that sort of biofeedback mechanism with them, and so that they could perhaps see how they could regulate some of their emotions and so on, I mean, where does that leave them? Do they then have to, have lots of repeated sessions in the scanner? I mean, is that sort of a viable or a feasible, application that these people will be able to use this? I think that's. Yeah. I'm interested in the practical side of it.
Well,
really.
Yes. Honestly, we're still fairly far away from such practical questions. But yes, but of course we have to consider them. And one outcome we don't want is if we came up with something that was really useful, but that would only work for last for a week, and then they couldn't because. We couldn't offer them the scanning sessions, and we would say, sorry, that's it. Well, the hope would be that the strategies they learn would become independent from the actual brain feedback, and that it's something that you can take home with you and practice at home, and perhaps with a few booster sessions in the scanner once in a while, may be able to continue. But I mean, at the moment, it's just all pretty much a fantasy as far as this is concerned. But what you're highlighting here, and which is very important, is these. If we do it on ourselves, that's fine. If we started doing it with patients, it has to be embedded in a psychological therapy approach. And they, it shouldn't be in isolation. And that's why the addiction field is pretty good, because it actually, we're quite surprised to see how closely it actually is related to strategies that are being used in motivation research for addiction anyway, just sort of enhancing the kind of cognitive and behavioral techniques that are being used anyway. Yes, it in a clinical context shouldn't be used in isolation, because we wouldn't be able to, even if we were successful, to make that to develop that to a sustainable.